let's start looking at some interesting aspects of natural history of atopic dermatitis. You'd think we'd have the data to really tell our patients what the chances are that if they start with eczema at a year of age, that by 12, what's the chance that it'll be gone? But there've actually been a few studies that have really raised a lot of questions about that. Historically, we thought most atopic dermatitis starts in young children. Most of that goes away over time. That's an oversimplification. While childhood atopic dermatitis is quite common, there are different patterns of onset. And the Paternos study put together these very large birth cohort studies and showed tremendous variation. There are children whose eczema starts early and it persists. There's children whose eczema starts later and then remits. And there's other children that starts later and persists. So there's this variations with no predominant group really predicting what will happen to just one individual over time. On the other hand, there's this data that shows that there's a significant persistence of atopic dermatitis, probably at the 9% rate in the US, elsewhere around the world, into adolescence and then adulthood as well. But there's also adolescent onset and adult onset atopic dermatitis. So from a prevalence standpoint, there's plenty of disease out there and plenty of work to do to try to minimize its impact on individuals. We still have questions about a sense of the pathogenesis of atopic dermatitis. How much is this genetically programmed process? How much is a barrier dysfunction at birth or in the first few months of life, which sets up open skin, and how much is just immune dysregulation? And it doesn't make sense to argue what the influences are because they're all active. So we can predict that some children with very dry skin will have a higher rate of developing atopic dermatitis, and there are prevention studies looking at different types of moisturizers to see if we can prevent atopic dermatitis in those individuals. We know that the skin's an entryway for things that will sensitize the skin, which then creates this immune reaction. And then we know that there is immune dysregulation. There's inflammatory cytokines in inflamed eczema skin, and in more severe cases, even in non-lesional skin and blood. And we know that when you have a lot of inflammation in the skin, it actually causes the skin barrier to be not as effective in doing its work, and it decreases the function. We also know that therapeutic interventions, either topically, sometimes with moisturizers, or with anti-inflammatory medicines topically, whether it be topical steroids or non-steroids, or with systemic medications, whether they be steroids, not advised, or non-steroidal systemic medicines, they can both decrease the immune stimulation and immune mediation of the disease, and also secondarily impact on the skin barrier so you have a better performing skin barrier. There's sort of a marriage of the different influences that create atopic dermatitis play out in our management, where we direct our management towards minimizing barrier dysfunction, but also minimizing inflammation. I've become very aware of how early we are in the game in terms of figuring out our subtypes of atopic dermatitis. I actually, in my World Congress talk, did a quick slide showing an example of a child who just looked like he had severe atopic dermatitis, who was part of a group of patients who were shown to have CARD14 mutations causing their atopic dermatitis. Now, it's not that I think many patients have this particular rare genetic disease, but it's just an example of how if you saw that patient in clinic with severe atopic dermatitis, you'd have no idea that there's a specific genetic cause in that individual. So endotype analysis in atopic dermatitis is really still very early on, but I think having had 10 to 15 years of psoriasis biologic history, coming into the age of our increased study of atopic dermatitis, partially aided by biologics as well as new topical therapies, will give us the just core interest and knowledge to start to look at aspects of both physical presentation or endotyping, as well as potential genotyping, to be able to do a better job predicting course, and most importantly, to helping us to select perhaps specific therapy, which will mediate the disease in a different way than just symptom control. So one of the things that we're noticing in atopic dermatitis is that our sense of comorbidities is really evolving and expanding. We have our traditional atopic comorbidities that we know about. Food allergies more common in children with atopic dermatitis. Asthma is more common with atopic dermatitis, and allergic rhinitis is seen in at least a third of atopic dermatitis individuals, even by a few years of age. But there's an expanded set of conditions that we see that can be associated. Eosinophilic esophagitis, we're seeing studies on neurologic effects. So anxiety and depression are clearly increasingly common or noticed to be common in atopic dermatitis patients. Attention deficit hyperactivity disorder is more common. What's from inflammation, what's from years of sleep disturbance isn't certain yet, but these clearly impact on the individual. There's emerging epidemiologic data on higher rates of heart disease, cardiomyopathy in adults. It's been intriguing. There was just a paper out about dementia being more common with atopic dermatitis. These I call emerging comorbidities because there are not multiple studies yet to see that they're clearly a phenomena. There's some regional differences around the world, but our expanding sense is pretty clear that atopic dermatitis has a broad impact on the individual over a lifetime.